Good day and welcome to this SCAGO Summit 2023 session. I am Dr. Soji Jemitola from SCAGO and I will be your moderator. Our topic today is Beyond Hydroxyurea, Other Emerging Therapies, which will be presented by Dr. Kevin Ko. Dr. Ko is an adult hematologist and clinician investigator in the Red Blood Cell Program at Toronto General Hospital University Health Network. He's an associate professor at the Division of Hematology and an assistant professor status at the Institute of Health Policy Management and Evaluation, University of Toronto. His clinical focus is on rare congenital hemolytic anemias, and his research focuses on genetic modifiers and innovative therapies in rare congenital hemolytic anemias. He focuses on the impact of white matter changes on neurocognitive outcomes in sickle cell disease and non-chelating strategies in the treatment of iron overload. Before we get started, let's go over a few housekeeping guidelines. This session is being recorded and will be made available through the SCAGO website, which can be accessed at sicklecellanemia.ca. Kindly note that the information shared during this summit does not constitute medical advice, nor replace healthcare professional counsel. Your microphones have been muted for the session. You are, however, encouraged to ask your questions or share your comments through the chat window. If you would prefer to ask your questions verbally during the Q&A session, please raise your hand via the reaction button, and I'll ask you to unmute yourself and ask your question or make your comment. Please ensure language is respectful. You ensure there's mutual consideration and relatedness with the current discussion topic. I will keep an eye out for your comments and share them with Dr. Ko during the Q&A session at the end of his presentation. SCAGO will also be sharing a short poll with you at the end of the session. Please use it to share your feedback about presentation so that we might better serve your expectations. SCAGO recognizes that the summit applies to a wide and diverse audience. I am therefore pleased to let you know that you have this session and all other SCAGO Summit sessions can be captioned in your preferred language. To activate that function, click Show Caption at the bottom of your summit screen, select the Enable Translation checkbox, and finally, choose the language you want the captions to be translated to. Now that's enough from me. I hope your seatbelts fasten because this will be an interesting and exciting journey about the innovative therapies in sickle cell disease with the eminent Dr. Ko in the driving seat. Here's Dr. Kevin Ko. Thank you.
Thank you, Dr. Jemitola. Thank you for the very generous introduction. I will share my screen now. So today, I am actually coming from Philadelphia, where I'm talking to you about Beyond Hydroxyurea Emerging Therapies for Sickle Cell Disease. Well, you're going to ask me, what am I doing in Philadelphia? Because the temperature in Philadelphia is pretty much the same as Toronto. So why? And it's because here I'm at a conference that we're also talking about the same topic, is that what are the alternatives to hydroxyurea for people with sickle cell disease? And with that, I will move on to the next slide. These are my conflict of interest disclosures. Today's objectives will be to review the evidence of currently approved disease-modifying therapies in different jurisdictions. We're going to talk about the unfilled gaps that are with the currently approved therapies. We're going to look at what are some of the other disease-modifying therapies that are going through clinical trials right now. And we're also going to look at the safety and also efficacy of the different types of potentially curative therapies, including stem cell transplant and gene therapies. And then at the end of the day, I'm hoping that we can stimulate a debate on the value of choosing a disease-modifying therapy versus these potentially curative therapies. As we all know, sickle cell disease disproportionately impacts those in the low to middle income countries, where you can see here births of sickle cell anemia per 100,000 births here. That was categorized in 2015. It's a bit of a modeling as an estimation, but you can see that majority of patients are located in the sub-Saharan African region. And it's important for us to keep in mind that the quality of life of a person with sickle cell disease is very similar to other cancer patients that are on treatment. You can see here, with one, the top represents pediatric or children's, and then the bottom represents adults. And you can see here a child with sickle cell disease has this very similar quality of life as a child of cancer on treatment. And same as in adults. In fact, in adults, the quality of life of a person with sickle cell disease is lower than a person with cancer who is on treatment. Now, this is a very complex diagram, but I just want to tell you that the reason I'm showing you this is not to teach you through the entire mechanism, because that's probably going to take 2 to 3 years of my life. But what's important here is to show you the complexity of what sickle cell can do to a person's body. And remember, this is happening every second, every minute of a person with sickle cell disease lives, right? The red cells are constantly breaking down, or they're stuck because of the what we call vaso-occlusion. That's essentially being stuck in the blood vessels. And when that happens, oxygen is not delivered to the tissues that needs them because of the anemia. And it's important for us to remember that sickle cell disease is more than just painful crises. I mean, from head to toe, we know that sickle cell can cause stroke, what we call silent infarct. There are these silent strokes. It can cause a dreaded complication called moya, which is essentially these overgrowing blood vessels because of the lack of oxygen in the brain. It can also cause retinopathy, which is essentially sickling inside the eye, causing blindness, asthma, acute chest syndrome, which we often call chest crises, and pulmonary hypertension because of its attacks on lungs and the heart. Asplenism, we know that by age 6 to 7, most people with sickle cell disease would have lost the function of the spleen. Of course, this leads to more infection. This also, because of the breakdown in the blood, leads to gallstones. That's what cholelithiasis is, gallstones. And also there's a small but appreciable chance, around 2 to 5% chance in a lifetime, of having the sickle cell attacking the liver as well, called hepatopathy. It can also attack the kidneys, causing kidney problems. In babies and children, I'm sure some of you have experienced this awful complication called dactylitis, where your fingers or toes would swell up and be red, very hot, very painful, essentially sickling of the hands. Avascular necrosis is the outcome, that the dead tissues in the bone as a result of the constant sickling that some people would develop. 4 out of 10 people would develop. Low bone density, many of you obviously have low bone density, leg ulcers. There's a small chance of getting aplastic crises. And of course, for women, could be pregnancy complications. And the most important thing to remember about sickle cell disease is that it doesn't cause just one of these many complications. It can cause a combination of these complications. And currently, we do not have the technology to predict who's going to develop what. And you can see here, though, on average, that many of these complications listed on the left here that I've just talked about affect anywhere between 11 to 35% of the people with sickle cell. But most importantly is that they usually happen at an age when most of us wants to further develop our professional or personal career, right? This is a time when we would think about, say, finishing up with our education, going to get a job, settling down, maybe falling in love, have a family. But these complications that people with sickle cell disease experience robs them of the opportunity to enjoy their life. This results in reduced quality of life, disability, morbidity, and most readily, of course, is early mortality. And you can see here that despite the advances in us helping people with sickle cell disease, you can see here that the average life expectancy is still much lower than, say, what Canada or the average Canadian. On the right-hand side here for male and female, with based on StatsCan results, you can see here is males is 79, females is 82. If we look at the states, which is on the blue graph on the left here, the 3 blue graphs, you can see they're a little low, but we can say that there's lots of other issues in the states that we're not going to dive into that could be causing the low the short life expectancy. But then even if we look at the UK, for example, which is the red bar, you can see that it's still at least 10 years lower than what the average life expectancy would have in Canada. Currently, there's 4 therapies, but you can see from this graph here, from this table, that they're not all uniformly approved. In the States, they have approved hydroxyurea, L-glutamine, voxelotor, and crizolizumab, but there are issues with these drugs, and I'll go through them briefly, such that the EMA, the European Medical Medicines Agency, has refused authorization of L-glutamine. They have revoked the authorization of crizolizumab. The United Kingdom's health authority has also refused L-glutamine, and there's a debate as to whether they're going to revoke the crizolizumab. For Canada, though, we are falling behind all of these countries. Remember, EMA covers the entire European Union, right? FDA covers US, and UK covers UK, of course. In Canada, none of the drugs are approved for use in people with sickle cell disease. So what are some of the issues of some of these newer therapies beyond hydroxyurea? Well, the L-glutamine, we don't exactly know what the mechanism is. In the phase 3, the pivotal study, where it was a randomized controlled trial, where they compared placebo with L-glutamine, there were fewer pain crises and fewer hospitalizations. The problem, though, is that the way they impute, or which is the fancy way of saying how did they know about people who dropped out, what happened to them? Because in this study, 36%, that's 1 out of 3 people, more than 1 out of 3 people who went on L-glutamine dropped out of the study. And the company basically said, well, for those who dropped out, why don't we just assume that they're going to have the same effect as, say, those who didn't drop out? That is what we call imputation. So you guess what would happen to them. But the FDA thought that that was a huge bias in terms of that. I mean, you really shouldn't assume that people who drop out of the study is going to have the same outcome, the same effect as those who stayed on. So when they redid this whole statistical analysis, they actually found that it wasn't, the difference wasn't that big between those who are on glutamine and those who are on placebo. And this is why the European Medicines Agency has actually refused marketing authorization of L-glutamine in 2019. Now, voxelotor is one where it helps the oxygen bind more tightly to the hemoglobin, so the hemoglobin doesn't sickle as much, right? Remember, because that's where the sickling happens, initially is in the hemoglobin itself. However, the studies is only what we call conditional approval, meaning that they actually haven't demonstrated that there is a reduction in pain crises compared to placebo. There are some studies that it may help to improve oxygenation in the brain, but that's still sort of in debate. So voxelotor is kind of in a limbo in terms of whether it really works in people with sickle cell or not. Lastly, crizolizumab, which is an antibody that's built to prevent the sickling, the attachment of the sickle cells to the blood vessels, so it prevents the clotting. You can think about it as like a Drano of sorts for the for blood vessels. But this one, initially, they saw that there was a good difference between those who are on the drug and on the placebo. Then they were asked by the FDA to rerun the study, the randomized controlled trial. And when they rerun it, and when they compare even a higher dose of crizolizumab at 7.5 milligram per kilogram versus 5 milligram per kilogram versus the placebo, they actually found no difference between them. And because of this result, the European Medicines Agency has revoked authorization of crizolizumab. And in the States right now, it's still approved, but the future is somewhat threatened. Why do I think that they actually found a positive result initially, and then they didn't find a positive result later? I think has to do with the fact that the way to define pain crises is a little different, but we'll need to see whether that actually pans out to be the true reason. Because in the old trial, they said that is is a pain crisis that resulted in a visit to the emergency department or hospital. But in the new trial, they said that even if crises that can be managed at home, they still count it. So, it could be a little differences because of that we didn't see a positive result of the drug. But again, the verdict is still out, which means that there's still lots of room for us to develop newer agents, right? That could probably hold more promise than what we've seen so far. In gold are the ones that have been improved. Arginine is currently in phase 3 study. The ones in orange are the drugs that have been being tried in the phase 2 so far, that are being used in phase 2. There's lots of drugs in the phase 1, but the next one I'm going to show you is those drugs that failed the clinical trial scrutiny. And you can see that there's a number of drugs that has been tried in people with sickle cell already that has shown probably not to have any good effect. And then there's a few that we just don't know what's going on. So with that in mind, I'm just going to go through some of these that are being developed in Canada. So arginine is not being developed in Canada, but it's worthwhile to mention because there's 2 phase 3 trials right now that are in children, and they're looking at to see if arginine can help with the pain crises in patients during a pain crisis. Next one is what we call pyruvate kinase activators. In fact, there's 2 compounds right now. There's mitapivat and etavopivat. What does it do is that in red blood cells, all cells needs to make energy. The energy batteries are called ATP. When a cell goes through sickling, a sickle cell goes through sickling, it uses a lot of these batteries such that it uses more than we could ever provide. And this is why the red cells would start sickling, and irreversibly so. More so is that during this process, there's a buildup of a compound called 2,3-DPG. And the buildup of this compound actually can cause more sickling, paradoxically. So making it even worse because it pushes the sickle hemoglobin to offload the oxygen. Once oxygen is offloaded, then it's carte blanche for the hemoglobin to sickle. What this drug does is that it works on the last enzyme of this pathway called glycolysis. So it generates more ATP, it makes more of these batteries. By making more batteries, it allows us to not just increase the amount of energy available in red cells so that there's less breakdown, there is less turnover, longer life, right? The red cells will live longer. In addition, it depletes or lowers the amount of 2,3-DPG such that it binds onto oxygen tighter. Now, that sounds good in the lab. Does it really happen in humans? Well, here's a phase 1 and phase 2 studies results. You can see here that the 2,3-DPG with increasing doses does drop. The P50, which is essentially showing how tightly it hangs onto oxygen. It hangs onto oxygen more tightly in graph B here. The amount of sickling and breaking down of the red cells is lower. You can see in panel B here, the amount of ATP, which is these batteries, have increased. And more importantly, it increases hemoglobin as well. So that's one. What about etavopivat? That's the sister drug to mitapivat, I so call it sister drug. They're pretty much the same thing. They act on the same enzyme, pyruvate kinase activator. So in this one, pretty similar. There's an slight increase in hemoglobin, a reduction an improvement in the binding to the oxygen, the P50 value, reduces the sickling point, it improves the deformability, and it improves the ability for the red cells to detoxify themselves through GSH and superoxide dismutase. Because of this, there's now a phase 2-3 study called Rise Up mitapivat. They just finished a phase 2. Results will be published very soon at the American Society of Hematology meeting. I'm looking forward to reading about this. But in addition, there's also the phase 3 study that is ongoing right now that people are being recruited into it. It's a randomized controlled trial looking at mitapivat versus placebo, and there's an open label extension for another 5 years or so. A similar study for the etavopivat for the sister drug is called Hibiscus and Gladius. These are this is the two studies that we're talking about. Again, it's very similar design to the previous study, to the Rise Up, in that you're looking at comparing etavopivat to placebo, and then find the right dose for etavopivat, and then again comparing it to placebo in the next part of the study. And then there's also an open label extension at the end, as you can see. So those are the phase 2-3 studies that are ongoing right now. What about the phase 2 studies? So just to clarify what phase 2 studies are, they are obviously they're between 1 and 3, but more importantly is that they look at safety, but they also try to look at to see if the drug is effective. So there's a mix of the goals of phase 1 and phase 3, because in phase 1 it's completely based on safety. Is the drug safe? That's what they're asking. And then in the phase 3 is they're asking, we know the drug is safe, but is it truly effective? So phase 2 is kind of in between. And currently there is a drug called NDEC-THU, or decitabine tetrahydrouridine, very long name, but make it simpler. It opens up the DNA. Why do we want to open up the DNA? We open up the DNA so they can start making baby hemoglobin, right? Fetal hemoglobin. We all know that people with sickle cell, when they were very little, when they were babies, they don't have pain crises, right? Until probably around 6 months or so, even later than that. And the reason for that is because they have these things called baby hemoglobin and fetal hemoglobin protecting them. This is how we think hydroxyurea works. We don't actually certain exactly how hydroxyurea works, but we think that's how it works. But in this case, this is not hydroxyurea, it's completely different. We know exactly what the mechanism is, act on an enzyme called DMNT1. But regardless, it does boost the fetal globin. And what we're trying to do here is to find an alternative that can boost fetal globin, but also to prove that it's also safe. So that's why they're running this study right now, is to prove that it's safe. So far, if you can look at the bottom here, in terms of the adverse event for the study, they're really they're not that severe, because they're all grade 1s to 2s. So it's pretty promising. So right now we're doing that study. In fact, this study is run in both Toronto as well as London, Ontario. So if you're interested, please let your doctors know in these cities, and we can get you into the trials. I should also mention previously that the Rise Up and the Gladius and the Hibiscus studies are also run in Canada as well. So ask your doctor about it. So this is the ASCENT-1 trial that I was just talking to you about. Now that we have talked about all the potential options for clinical trials in Canada with drugs, let's talk about gene therapy, right? Because this is something that we're all interested. So what is gene therapy? The idea of gene therapy is to take the person's stem cells, okay? We don't do bone marrow harvest anymore. In fact, we just use a machine to siphon up the cells. Once we take the cells out, and the way you siphon it is just through like a transfusion. It's kind of like a reverse of a transfusions, where we just take out the stem cells. Once we take out the stem cells, we modify it, we change it, but before we give it back to the person, we need to let me use a laser pointer. Yeah, before we give it back to the person, we need to make sure that we've cleaned house. So we need to use chemotherapy called busulfan or melphalan to clear the bone marrow before we can give these modified stem cells back. Well, what is the advantage of gene therapy over stem cell transplant? We don't have to worry about graft versus host disease, which is a dreaded complication that you get with stem cell transplant. We don't have to worry about donor availability, because you yourself are the donor. We don't have to worry about graft rejection, because again, you're yourself. However, things like infertility, the chance of having cancer, the chance of other complications from transplant is really dependent on the type of chemotherapy that's being used to clear house before the modified stem cells is being put in. Also, of course, with sickle cell disease, as we know, as we age, there's more complications that can develop with sickle cell. So, and lastly, not the least, of course, is the cost to the wallet. So how do we then change the cell? So one way is to send a love letter. The way it works, and courtesy of Dr. Julie Cantor, she actually drew this. It's really cute. Essentially, we take HIV virus, we take out the instructions that to make HIV, and we hollowed it out. Essentially, we put the hemoglobin gene into the letter into the envelope, the lentivirus, which is HIV virus, and we seal it, and then we deliver it into the cells. Well, how do we ensure that people don't get HIV in the process, right? Because obviously we're using HIV vector. The way we do it is that, first of all, we make it replication defective, which means that it can't make itself copies, okay? Once it gets in the cell, it just delivers the sickle hemoglobin. It doesn't do anything else. The other thing is that it's self-inactivated. It's kind of like Mission Impossible, your letter will self-destruct in 50 seconds type of thing. Also, we need to protect the new hemoglobin from being silenced because we need it to make. This hemoglobin also needs to be able to interrupt the sickling process, right? So we tailor design these hemoglobin. One of them is called T87Q. The other one is called AS3. These are anti-sickling hemoglobins. Last thing is that we also need to make sure that this hemoglobin is being made. So we have a thing called locus control region, which controls it, which controls the making of the globin once it gets into the stem cell. So with this, you can see here that people have been getting excellent results. 35 patients in the group C of the Bluebird Bio trial shows that you can see on the right-hand graph here, right? Hemoglobin, total hemoglobin is around 130. Okay, the American units is 13, but it's the same. You can see here that the T87Q represent, the anti-sickling hemoglobin represented by the orange red bar here is like around 53%. Essentially, the person has been converted into traits. None of these patients have any crises afterwards. However, in group C, there's no cancer, but in group A, there were 2 people with leukemia, which I'll go through briefly later on in terms of why. One at 3 years, the other one is 5.5 years. The other way of doing gene therapy is to edit the cell. So before we talked about inserting a new hemoglobin gene, an anti-sickling gene. Here we're talking about somehow remaking fetal hemoglobin. So how do we make new fetal hemoglobin? What we're going to do first is to deactivate certain genes that controls the fetal hemoglobin so that it can start being made again, so-called repressors. And the way we can deactivate these repressors is using these molecular scissors called nuclease that cuts the DNA. Now, we don't want this cut to happen anywhere because then your DNA was completely fragmented and it's completely useless. The cell would die. Then we need a way to specifically target these repressors. And the way we do it is using things like zinc fingers or talons or CRISPR. You probably have heard of CRISPR. CRISPR is just the guided RNA part that guides the nuclease, right, which the molecular scissors, to cut at the right place. Once it's cut at the right place, the cell would hurry up and try to repair itself, but there is a chance that the repair doesn't work. And we want that to happen. We actually don't want the repair to work. What we wanted to do is maybe insert a couple of extra letters into the sequence, or maybe delete a couple of letters, because once you have inserted or deleted a couple of letters, the entire sequence doesn't make sense anymore. And the cells recognize that and say, oh, I can't read that. It's a mumbo jumbo. It means that the repressor has been deactivated. Once you've deactivated the repressor, then you can start making fetal globin. So here is the case. So by deactivating a gene called BCL11A, using this CRISPR approach, this molecular scissors basically cut the BCL11A, we can start making fetal hemoglobin again. There is 2 types of Cas system, the Cas9, which made famous by Vertex. You probably have heard of Vertex as a company that does this trial. Another one is called Editas. Editas uses Cas12a. There's subtle differences between the two. If you want to know more, I'm happy to address them at the end. But let's move on. So how well do they work? Well, they have done a pilot study so far, right? That's been published, right? And every patient of the 6 patients has been grafted using this CRISPR method. And you can see here that, fetal globin is between 20% to 41%. Not bad overall, right? Most people on hydroxyurea, some do achieve 20%, I would say, at least in the clinic, but, 41%, very few people would achieve 41%, even on hydroxyurea. So, and then here's another publication on CRISPR-Cas9, right? Again, we're cutting the BCL11A, so we deactivate it, so we allow fetal globin to make itself again. You can see here on the panel C on the right-hand side that, around, instead of around 10%, now, we have 30% fetal globin. And then there's, of course, Cas12a, which is done currently. This trial is being run in Toronto right now. Previously, I should say, by the way, I should also say that the CRISPR-Cas9 trial was done in Toronto as well as in BC, at BC Children's. Now with this one, the EDIT 301, the CRISPR-Cas12a, that's being run in Toronto right now. And the people that the study is looking for are those who do not have a matched sibling donor, because you have to show that you have a need for stem cell transplant first, but then you don't have any donors in order for you to qualify for the study. You can see here that is pretty spectacular. The amount of fetal globin you can see here is around close to 50%, 44.3% in subject 1, 38.6 in patient number 2. The F cells, which represents the amount of cells that cannot sickle, is around 96%. So almost 100% of the cells are not sickle. And these patients have no pain crises. In addition to all those techniques, if we look forward in the future, there's this thing called homology-directed repair. I'm not going to bore you with this. Slides will be available so you can read them over later on. Bottom line is that this is a very directed approach at correcting the actual mutation, the sickling mutation. There needs a lot of helper vectors, and so we use adenovirus, which is a type of, it's a virus that causes common cold, to help with carrying this repair, this disruption and repair. So it's a little complex in terms of, more complicated than what we've done before, but the idea here is that it will be even more specific in terms of how we're correcting these cells. You can see here that currently there's a lot of gene therapy trials going on. Some have been inactivated, some are still going. The ones that are ongoing, Boston Children's, Bluebird Bio, Graphite, UCLA, Vertex, as you know, is currently ongoing still. And then there's an Editas trial, and so on and so forth. So what about that leukemia case that we talked, the 2 leukemia cases that we talked about? So let's dive into those a little more. The differences between the early stages when people were doing this, the gene therapy, versus later stages now, is that they were using the bone marrow as a source for gene therapy. There was difficulty with engraftment. What we think, or what the scientific community think after analyzing the DNA in this patient and the other patient as well, is that when you look at the DNA, there was no modification by the vector on the AML cells, but rather is thought that maybe is the chemotherapy that has caused the leukemia. Well, why is that? Well, let's dive into that a little more. People with stem cell transplant, people with sickle cell disease who undergo stem cell transplant have a chance of having leukemia, and specifically is 1.7% chance within 10 years of having leukemia. And any sort of secondary cancers is around 2.4%. So it's not low. I mean, it's low, but not that low. More so is that the risk is even higher with what we call low intensity or non-myeloablative regimens. Furthermore, people with sickle cell disease, unfortunately, have a higher risk of leukemia to begin with. Hospitalization data in England shows that, there's a 3 to 10-fold increase of incidence of blood cancers in people with sickle cell disease. There's also a 72% chance increased risk of having cancers in California when they compare to the general California population. So you're going to ask me, why is that? Well, there's a number of factors that we think is going on, none of which have been completely elucidated or found out yet. It could be the chronic lack of oxygen that the bone marrow is going through day in, day out because of the sickling. It could be these things called reactive oxygen species, which is just nasty. I mean, it's like hydrogen peroxide, for example, that could be causing the damages that are being generated as a result of the sickling process. There could be damages to the blood vessels because of the sickling. The fact that these cells are replicating very quickly because of the fact that the person is always anemic. There also may be a selection pressure on these so-called pre-leukemic clones to make them even more susceptible to develop the cancer. So we talked about the potential risk, right? That it's not going to engraft. We talked about the chance that it may cause cellular transformation of the cells. It can cause cancers. It can cause what we call off-target effects, meaning that the genes that we want to, the anti-sickling hemoglobin gets inserted in the wrong place, for example, or that we cut the wrong gene, for example. These are some of the potential or the theoretical risk. Well, how do we mitigate this? The US FDA has mandated that any trial that's being run, and this applies to Canada as well, any trial that's running gene therapy needs a 15-year follow-up. It is mandatory that there is surveillance for those who have gone through gene therapy for secondary cancers, and also to make sure that there is no what we call off-targeting surveillance, meaning that again, the disruption doesn't happen to other innocent bystander genes, and that it's only modifying the intended target. Last but not least is, we need to talk about dollars and cents, right? This is not a drug that you can go to Shoppers or Rexall or London Drugs to get, right? We are talking about a 2.8 million US price tag here, right? How is that going to work in places like Canada where we have universal healthcare, right? How can we afford this? And then the question, the flip side of this, of course, is how can we not afford this, right? Because sickle cell disease is simply so devastating to a person's livelihood. How can we not afford it? So how can we make this? So the next question would be then, how can we make this affordable for Canadians, especially the currently strapped and underfunded public healthcare system? And so, we have to start making our choices, right? Do we want to modify the outcome of sickle cell disease so that we're still living with the sickle cell disease, but then we put in a better trajectory so that, that there's less complications? Or should we strive for the cure once and for all? And remember, modification means you're controlling, but you're not curing. But with the stem cell transplant and the gene therapy, we talk about what we call high risk, high reward. We talk about the risk of cancers, infertility, and so forth. But then the reward is great, right? Because obviously you get cured. The important thing right now is that with the curative therapies, there's very limited inclusion criteria. There's also issues of accessibility, right? Are you willing to be an early adopter? Meaning that, are you willing to try something out? I mean, this is not like trying out, the newest version of the iPhone, right? Look, I mean, if you go out there, you try out the newest version of iPhone, like iPhone 15, and you find that it completely sucks, I mean, at most, you're going to be losing what, like $2,000. You're not going to lose your life, right? But with some of these therapies where it could be potentially pretty harmful, you can be losing things like fertility and maybe getting cancers and so forth, right? Like how much of a risk taker are you to go through these therapies? But that, of course, needs to be equated with the amount of suffering that the person is going through to make it justifiable. And then the last thing is, are we trading one complication for another? And this entirely depends on how each individual views their own life and what they want to do. Like ultimately is their own destiny that they'll be controlling. So when we go through these discussions, some of it's very person specific. There's no one size fits all with these conversations, and it's important to listen, for us as doctors, to listen and ask what the patient wants, because ultimately it's not my life that's at stake, is whoever's sitting in front of me whose life is at stake. And lastly is, we talk about making it affordable. Right now, Canada's healthcare system is like this in terms of approving a drug or a new process, right? You have Health Canada that just looks at the efficacy and safety of the drug. Once they think that they believe it's efficacious and is safe, then the next step is called they'll look at to see whether it's worth it or not. Once they've said that, they've given a rubber stamp and they've given a stamp of approval saying that it's worth it to fund the drug using a whole bunch of calculations, statistics, modeling, then they will forward it to another group called PCPA, because they don't set the price, the CADF and ANES. They just say that, yes, it's worthwhile to fund it. Then it's up to the Pan-Canadian Pharmaceutical Alliance, or PCPA, and this is composed of a group of pharmaceutical companies and a group of all the provinces. And the provinces will sit together and negotiate with the pharmaceutical company in terms of how much the drug should cost. So this is where the PCPA level. So they come up with a memo and saying, okay, this drug, if being reimbursed by the public payer, should cost this much, X amount of dollars. But that doesn't mean that the province is going to fund the drug, okay? That memo could sit in someone's desk for 5 years and never see the light of day. Only if there is enough pressure for the provincial governments will the provincial government even look at that document and say, okay, let's decide on whether we should fund it or not based on the PCPA recommendation. They don't have to take the recommendation. It's just a guideline. It's not like a must, so that's another little negative complication. Fortunately, I do see an end to the light here. It's not just about griping. There is a national strategy that the government of Canada is building, the federal government is building, called National Strategy for High-Cost Drugs for Rare Diseases. I know people like Landray, for example. I know SCAGO has been involved, SCDAC has been involved, a number of these organizations. The court has been involved. That's the Canadian Organization Rare Disease has been involved in talking to the federal government about this. So the federal government has been given a good chunk of money. I think it was $1.3 billion to develop this national strategy. And one of the things that they want to focus on is in gene therapy. So stay tuned in terms of how we can hop in the bandwagon, because it's important that we do. Because if we don't, then this is all for naught. Okay, we need to be proactive. We need to liaise with the government, keep them, remind them that we exist and that we need help. And with that, I will draw to a close. I welcome any questions. Thank you.
Thank you, Dr. Cole, for taking us through an insightful and information-packed session. It was really, really a great session. Thank you very much. To the House, we are now in the Q&A session. Do share your questions or comments through the chat. If you'd prefer to ask your questions verbally, raise your hand where the reaction button, and I'll ask you to unmute yourself. We'll also be sharing a brief poll with you shortly. Please use it to share your feedback about presentations. So looking through the chat, I do see a couple of questions for you, Dr. Ko. You mentioned a number of therapy options today, with Canada lagging in therapy approvals for sickle cell disease. What is the outlook for achieving approval in Canada for novel and emerging therapies?
That's a very good question. I think it depends on a couple of things, right? I think it depends on our participation in the development of these new therapies. And how do we best, involve in the development is by participating in the clinical trials, because there is no incentive for the pharmacist, because it costs money, right, to submit the package to Health Canada to get approval. It's a lot of money to do that. And if they don't see a value in bringing the therapy to Canada because they say, oh, they didn't participate in any clinical trials, they must have not have many patients. And even if they do, they're probably not interested. So the important thing is that first thing is that we need to participate in these trials. Once you have done that, then we can have a strong voice in saying, please bring this therapy to Canada. You have seen already through your clinical trials that you have this many patients that you can potentially treat, and that these many patients need your drug here.
Thank you very much, Dr. Paul. I think you mentioned quite a bit of that during the presentation as well. But I think what is clear is that even we as in the SCD community, we have to realize that we have to be active. We have to actively put our voice together and advocate for these therapies, as we have a role to play in that aspect. Thank you very much for that. We have another question. And just before I read that question, I would ask for the poll to be launched. Please share your feedback there as you also post your questions in the chat window. Thank you very much. We're going to be multitasking a bit there. So are these therapies mainly from the pediatric perspective? If so, are there significant differences or ongoing trials for adults with SCD? What is the population mix for the trial?
Yeah, it's a very good question, because if you examine the transfusion trials, right, for people with sickle cell disease and the hydroxyurea therapy trials, they were all done in the pediatric population first, right? And then we take those evidence and we translate it into adults and say, we're going to continue on using this because as a child they have been using this and it's pretty good. Right now is a completely different landscape where these trials are mainly adult focused, and once they're proven to be safe in adults, then we will translate it into children.
Thank you very much for that, Dr. Ko. We have a comment here a question from the room. I do need to, before I read the question, and I do need to preface this, that this forum is not a channel for medical advice. It's for informational purposes. We do have that disclaimer there, and does not replace counseling with your designated healthcare provider. However, Dr. Ko, the question reads, what is the best therapy for a 64-year-old female still working, but going through eye and teeth damage and daily pain in the hip and knees?
Well, as I said in my concluding slides, it's very important for that person to talk to their doctor, their sickle cell provider, because only through dialogue can we find out what is the most appropriate therapy for that person. And it's not about me or the doctor recommending, it's about what the patient wants.
Okay, thank you very much. Again, that speaks to the role we have as patients and members of the SCD community. We have another question here. It relates to a graphic you shared during your presentation, illustrating the number of sickle cell births on a global scale. And the comment is, how is it that Canada is reporting 0 births? What steps, if any, are being taken to address this information gap?
That's a very good question. That graph, right, that graphic was published in 2013 by Pael. It's an population estimate based on a geostatistical modeling, which is based on an earlier paper in 2010. And the way they generate those statistics is through polling of individual sickle cell centers. Now, back in 2010, we didn't have a lot, if you remember, right? There was only a few centers available, and consequently, only 3 centers were polled in Canada. And even at that time, even now, let's say, not even at that time, even now, we don't have a registry. Do we truly know how many people are suffering with sickle cell disease in Ontario? Zero idea. I mean, it blows my mind because I have just another patient who reached out to me on email asking me about clinical trials. That's how he learned about the clinic, is through the clinical trials. So the fact that there are still patients out there not knowing that there is a treatment center available speaks to us the urgency of needing a registry so that we can properly characterize the number of people suffering with sickle cell disease in Ontario. And with that, then we can accurately estimate number of children being born with sickle cell disease, right? But until then, we have zero data on that. This is why they had zero. It's not because we had zero, it's just that we have no way of calculating and counting for the number of people in Canada.
We need the information, and thank you very much. An earlier speaker today spoke to that point as well, not only to the outreach and the expanding number of sickle cell clinics, but even the fact that we need to have data. Decisions are based on data. Money and dollar decisions are based on data. If we don't advocate, if we don't show the strength of our unity in a number of people, it's very tough to make a difference. So thank you very much, Dr. Cole. I do not have any other questions in the pipeline right now. At this point, I would ask you to please, if you haven't already, complete the poll. It has been raised. Please share your feedback about the presentation. And we also have a question about what are topics you'd like to see addressed in the future that are important to you. So please complete the feedback, the poll questionnaire there. Barring any other questions, I would like to say on behalf of SCAGO, thank you very much, Dr. Kevin Cole. Thank you very, very much. It's been a very insightful session. I learned a lot myself personally, and I'm sure the audience did as well. So on that note, I would say thank you very much, and see you at the next session in a couple of minutes. Thank you very much, everybody. Any final words, Dr. Cole?
Yeah, I mean, I just realized there's a couple more questions, so I'll just quickly answer. Okay. Yeah.
Missed that?
Yeah, Dr. Rob Klassen said, I'm just going to read them out.
Oh, I am sorry about that. I missed that.
Do you want to read them out, moderators, maybe? Yeah, I'll let you do that.
Okay, so from Dr. Robert Paulson, we have fantastic presentation. Disappointing that the FDA-approved drugs not seem to me to be holding up over time. Any thoughts if any of these drugs are useful for patients?
I think it's important for us to remember that not all drugs work for everybody, and that in certain subgroups, there may be hope that these drugs do work. One great example is called crizanlizumab. As we saw previously, that actually in the repeat phase 3 study, it didn't show any differences in pain crises. But what is currently now is that there's a phase 2 study called Spartan trial looking at specifically priapism, and it seems to be reducing the number of priapism episodes by half. And to those who do have priapism or have experience of loved ones with priapism, you know how devastating it can be. So there is value in these drugs, I feel, even though it doesn't work for everybody, that it could potentially work for some people for certain settings. And then the next one, Cherise, yeah.
Thank you very much, sir. We do have another question. Will it cost money for patients to participate in these clinical trials?
Absolutely not. If you qualify for the trial and you're willing to participate in it, it should not cost you 1 cent. In fact, today at the conference here in Philadelphia, we're talking about reimbursement. There is now even reimbursement for childcare, because we recognize that when people come to have their blood drawn and need to be in the clinic all day, their child needs to be taken care of. Their children needs to be taken care of. So even childcare are being paid for now, in addition to transportation and lodging.
Okay, thank you very much. So making it easier to participate in this clinical trials. Thank you. And just a side.
An important thing is for patients to tell us what you need, and we will certainly try to meet you full way.
Thank you very much for that, Dr. Kevin. I'd also like to point out that SCAGO has a number of research studies that are going on right now. And like Dr. Kevin mentioned also, there are some out-of-pocket expenses that are provided as well. So if you're ready to or interested in, please visit the SCAGO website and you'll be able to register for those clinical trials. Okay, we have a comment from Dr. Adekunle Adekile. The gene therapy strategy of representing BCL11A essentially converts the SS patient to one with the Arab India haplotype. Well, this is a very technical question, I think, where hemoglobin F levels vary from 20 to 40%. However, among the latter, the clinical phenotype is still heterogeneous, and in fact, some adults have a severe phenotype. Have we thought this strategy through, and are we concerned that some patients may not do well, especially as they grow older?
Yeah, Adekunle, I completely agree with you on this. So this is why I had one slide on directed homology repair, where we're specifically changing the mutation of the sickle hemoglobin. This is why I think that directed homology repair is actually the next step in gene therapy, and not just boosting fetal hemoglobin. To that point, there's one company that's looking at modifying the sickle hemoglobin into another hemoglobin called hemoglobin macrocell, which is completely inert. So stay tuned for those trials coming down the pipeline in the next few years.
Okay, promising therapies in the future, right?
Mm-hmm.
Okay, we have another question here. Are there any clinical trials that would be appropriate for those afflicted with kidney disease?
Oh, yeah, Trina, you ask an amazing question there, and I wish I have a good answer for you. In fact, we as a consortium of people, doctors with sickle cell disease, submitted a grant to NIH multiple times, advocating for a trial for people with kidney disease with sickle cell, and they keep turning it down repeatedly. Yeah. So unfortunately, no. We're almost as close to opening.
That is sad and challenging, right?
Yeah, it's the lack of funding, again.
Yeah. Okay, I'm going through making sure I do a double check on all platforms now. I do not see any additional questions, but I will thank you all for sharing your comments, questions, and like I mentioned earlier, this recording will be available subsequently on the SCAGO website. There are also current research, clinical trials that are ongoing. You can check with us. We can put you in contact with Dr. Cole, or also on the SCAGO website. So thank you very much, everyone, and look forward to seeing you at the next session.
Last thing is that for those who live outside of Toronto, you can also reach out to me. I will connect you with my colleagues who are running clinical trials in other areas in Quebec and Alberta and BC and so on and so forth.
Thank you. That's very helpful. So it's not just for Ontarians, right?
No, yeah, but even in Ontario, even if you don't live in Toronto, London is running clinical trials and sending a master and so forth. I can definitely connect you guys.
Okay. All right. Thank you very much, Dr. Cole. You've been awesome. Thank you very much, audience, as well. And for the third time, I will say see you at the next session. Thank you very much, everyone. Bye-bye.